I'm back again. This is my disclosure. Please consider during this presentation that I am involved with prosthesis producers like Lima and Zimmer Biomet. My topic today is anatomic or reverse, how I decide for it. First of all, we need to understand that when we speak about shoulder replacement, we are also speaking about different pathologies. That is just a degenerative joint disease, rotator-cuff arthropathy, capsular arthropathy, inflammatory like rheumatoid arthritis, post-traumatic, avascular necrosis. So we have different types of arthritis and we have different types of prosthesis. EMI, that still in some cases makes sense, anatomical, TSA, or reverse, RSA. Because again, facing different condition requires to have different options in our hands. Now, total shoulder versus reverse. Let's start with the total shoulder. What we need to have to get the good results with the total shoulder arthroplasty, we need to have rotator-cuff integrity and a good glenoid bone stock, especially after instability surgery with arthritis, and check the subscap. That is crucial. Also, not only the superior cuff, but also the anterior cuff is very, because anterior superior escape is a nightmare just in case if it is happening, but also the static posterior subluxation, so the bony condition, not only the soft tissue, so the two of them, bone and soft tissue, are important. So a static posterior subluxation can be a problem leading to failure. Always check then with your X-rays. The AMADA classification is providing us good information about it, but also with the CT scan and the Walsh classification, double check about the static posterior subluxation of the glenoid that plays a role in making a failure of total shoulder in the mid and long run. Another important thing that is coming to our attention is the critical shoulder angle that is not only related to rotator cuff failure, but also to the development of glenohumeral arthritis, and eventually may affect the biomechanics and the soft tissues balance when we make an anatomical replacement. So the outcome, we need to understand that we should do the proper indication, because not only a technical failure may happen, but the wrong indication. Some indications, they may look good, but then you have a rotator cuff failure, or you have an excessive glenoid retroversion, or you have a static posterior instability, and all of these are leading to implant failure. So indication, choosing the patient, plays a role in my daily life. Let's see the outcomes for the total shoulder. When you have a primary arthritis, in this paper here, at 10 years, so quite a long follow-up, 90% of survival, good one. But B2 glenoid, they have a relevant number of revision. Post-traumatic arthritis, you have 33% of survival at 10 years. So rotator cuff failure and tuberosity, as I mentioned already, are very important for that. Rheumatoid arthritis is performing good. Of course, you need to have a cuff, but it is very clear now. And shoulder fracture, the tuberosity malposition or non-unions is correlated with poor results. Necrosis, good results, but in this case, it can be an option. Let's move now to the reverse total shoulder arthroplasty. Classically, this was described in arthritis with failure of the rotator cuff, especially in the elderly, in the original indication. And the main issues for this were scapular notching, we know about this, instability, and the range of motion for the patient. So this is the notching described with the Nero classification that we didn't like at all, because it was somehow harming the stability of the glenoid component. And we understood then the excessive medialization and distalization of the implant may lead to this, leading both to notching for the contact here and the polyethylene debris, and also to some instability if the wrapping and the tension of the deltoid is not sufficient. This is why now, in the more recent evolution of this great idea of Grammont, we have many possibilities in our implant with the lateralization that may include both the humeral side and the glenoid side in order to improve this stability and preventing the scapular notching. The clinical outcomes, this is a study by Luc Favard. You see that basically at 10 years it is behaving very good with some declining of the outcome, but the clinical result with the constant score is basically very good even in the long term. 89%, that is a lot at 10 years with the original design of Grammont. Now it is becoming even better. Then let's see what happens when you have fracture, and comparing the salvage when you have a fracture and when you do a primary. And of course, when you have a fracture, the outcome is slightly lower when compared to a primary implant, and it is the same about complication. Contraindication, limits and caution for total shoulder and reverse. For both, sepsis is a problem. For anatomical rotator cuff deficiency, the glenoid version, B2 and C or B3, the static instability, whatever it is, bone stock needs to be analyzed, and of course some neurological disease that is probably very rare. Reverse, sepsis of course, the deltoid should work properly because it is related of course to the axillary nerve injury. Now, if we go to the numbers, because there is another window I want to open in this presentation, you see that there is an explosion. These are the American data with an explosion of the number of implants of total shoulder replacement. And these are the revisions, where other includes revision. You see, it is basically 7%, so quite a lot. So with this relatively old data, only the United States, over 3,000 revisions are expected. So the possibility of revising easily an anatomic to reverse is becoming more and more important to my mind. And I published the first big paper about this a few years ago, comparing two groups with the AMI failed for tuberosity resorption after a fracture, and the total failed also for rotator cuff. And the results were very good. No major complication, poor blood loss, and a quick procedure if you use a system that allows you to keep part of the implant in position, including the stem and the base plate. And this is reported in this review article comparing all the papers coming out, and my paper is demonstrating that it is clearly a benefit if you use a system that is helping you for revision, modular. And in fact, the glenoid component, these are the registry from Australia, is something that is happening quickly and frequently, and most of the cases of revision are related to the fact that you have a failure of the rotator cuff. So the benefit of modularity to my eyes is important. When I choose my plan for the patient, I try to use a modular system in order to be ready in case after 8-10 years to easily, let's say, easily convert the anatomical to reverse. And my personal attitude when I make my choice is then all the fact that I already described a second ago, but also the age is important, of course the cuff, the bone stock, the stiffness, and then I take my decision. I hope this was clear enough for you, and you enjoyed this presentation. Thank you.